So, so, so I would like to introduce Dr. Hussam Jabri. He's a consultant neurosurgery and spine surgery. He's the program director of fellowship, spine director of a residency program in Prince Sultan Military Medical City. He will talk about lumbar spine anatomy with lumbar intervertebral foramen anatomy, focus on endoscopic related anatomy. Please, Dr. Hussam.
Good evening. I will talk about lumbar spinal anatomy with endoscopic related intervertebral foramen anatomy in applied surgical anatomy way. Lumbar vertebrae are 5, identified by their heavy body and thick blunt spines process for the attachment of powerful back muscles and hence substantial axial loading and movement with increased incidence of trauma and degeneration. The articular processes are also distinctive in lumbar spine. The facet of the superior articular process are directed medially instead of posteriorly, and the inferior articular processes are directed laterally instead of anteriorly. The orientation of the facet varies as we move from upper to lower lumbar levels. And the upper levels, the facets are more oriented in the sagittal plane, where it is more coronally in the lower lumbar vertebrae. The intervertebral joint formed between the two consecutive lumbar vertebrae are 3. This is the two vertebrae. Here we have the intervertebral disc. Inferior articular process of the upper facet articulate with the superior articular process of the inferior facet, forming the facet joint capsule or the zygoapophyseal joints. The ligamentum flavum is thickest in the lumbar spine, and it connects, as seen in the previous slides of my colleagues, to laminae, and this runs almost vertically, and it has superior and inferior leaflet. These of two sides meet in the mid of the vertebral body and are subjected to buckling and narrowing of the canal. It is not only in the spinal canal, but also these ligaments extend laterally into the foramen, as we see in this animation and the sagittal and axial images. And in the foramen, it's approximately 5 millimeter inferior medial to the pedicle, and this is of importance during transforaminal approach because these ligaments can be identified and removed without risks. The ligamentum flavum can also be identified in the other interlaminar endoscopic approaches, like entering between the lamina of two spinous processes. We can identify the ligamentum flavum in the midline as a vascular yellow, and this ligament need to be removed in order to access the spinal canal. The lumbar spinal canal can be divided into zones, and this is of importance of clinical and surgical views, because in the central canal, where the coda equina and traversing nerve root can be compressed depending on the size of the lesion. Lateral to the thecal sac and medial to the pedicular line, we have another zone which has different names, paracentral, subarticular, or lateral recess zone. And here again, the traversing nerve root can be compressed. And the foramen between the two foramen, between the medial and lateral pedicular line, the lesions here can compress the exiting nerve root. And lateral to the lateral foraminal line resides the extraforaminal zone, which also can compress the exiting nerve root. Intervertebral foramen and interlaminar window are variable in the lumbar spine from upper to lower spine. So the foramina are getting smaller as we move down in the lumbar spine, but the interlaminar window in L5-S1 is the biggest and smaller to L4-5. This means we can adopt transforaminal endoscopic window for these foramina, while L5-S1, and also because of the iliac crest, we can use the interlaminar window, and here we can access the spinal canal. The foramen is bounded anteriorly by the vertebral body and disc, superiorly by the inferior border of the pedicle above, inferiorly by the superior pedicle of the level below, and posteriorly by the facet and pars interarticularis. As we see in the parasagittal MRI foraminal window, we can see the various contents of the foramen between arteries, veins, and nerves that we will come to soon. Directly different measures of the foraminal height varied between 11 to 19 millimeter, and the width anterior and posterior, it varies between 7 to 10 millimeter. This dimension changes with different people and pathologies, but an increasing age because the discs become dehydrated, so there is a drop in the superior and inferior diameter and hence decreasing height. Increasing height in tall people, the height of the foramen can increase, while in obese people, the width of the foramen can decrease. The intervertebral foramen divide into upper and lower part. The upper, which is more rigid part, and it has the nerve and the vessels. The lower part doesn't have nerve and vessels, and this may be safe entry to the spine, which we will talk about soon. This upper part tend to be rigid and not mobile. And as we see, if there is flexion, there is increase in the foramen size, but in extension, there is decrease in the foraminal size. Because of that, endoscopic spine surgery is done in prone flexed position. Contents of the foramen are spinal nerve, dorsal root ganglion, spinal branch, and the veins. Recurrent meningeal branch also, we will see it soon, and adipose tissue surrounding all these structures. If we come to the anterior intervertebral foramen veins, we have two venous plexus, the external venous plexus and the internal venous plexus. The external venous plexus is more developed around the anterior part of the vertebral body, and the internal venous plexus is more developed around the anterior part also and in the midline. These originating from the inferior vena cava, giving the lumbar vein, which unite on both sides and ascends longitudinally to form anterior longitudinal ligament. As we said, posterior epidural venous plexus is less well developed, and in the midline, these two connected, and the internal and external are connected by basivertebral vein and foraminal veins. The anterior longitudinal plexus run around the posterior vertebral body, and they come closer to each other around the pedicle and away from each other at the disc level. And in this picture, taken from endoscopic view of interlaminar, we can appreciate this venous plexus. The location of the artery in relation to the nerve is superior and anterior. As we see, it branches from segmental lumbar branch into anterior and posterior radicular branches, and all located in the upper part of the foramen. The spinal nerve exit the foramina of the lumbar nerve in different fashions. In the upper lumbar foramina, they exit in more right angle compared to lower, where they are more oblique. The thecal sac itself also tapers posteriorly, and this is important in endoscopic spine surgery because we expect the dural sac here earlier than here because it's away and it's also has tapered already. And this makes the interspinous portion of the upper nerves very short compared to distal nerve from L3 and below, where they travel longer distance in the spinal canal. Just Prior to the formation of the spinal nerve, there is a small enlargement of the dorsal root noted, and this enlargement, as seen before, called dorsal root ganglion, which contains small cell bodies of sensory neurons. And this is important because if we have disc pathology compressing here and compressing here, the patient will suffer of pain more because of the compression of the dorsal root ganglion compared of only solely compression of the spinal nerve. The DRG location and perspective to the foramen can be quite variable. Mostly they are located in the foramen, but it is variable. Upper lumbar level, they're located more toward the external portion of the foramen, and they come inside the canal slowly as we go down till the DRG of S1, which resides inside the spinal canal in 80% of time. And it is important because intraspinal placement of S1 DRG is at increased risk of injury from disc herniation or degenerative changes in L5-S1 disc and maybe more pain. The spinal nerve, after exiting the foramen, divides into 4 branches. The ventral ramus, which will go like this and will supply the muscles of the anterior and lateral trunk through cutaneous branches. The dorsal ramus, which divide into lateral, intermediate, and medial, and supplies the paraspinal muscle, facet joints, and the posterior arch and skin. We have the recurrent meningeal branch or the sinovertebral branch, as we see here, which supply the annulus of the disc and the posterior longitudinal ligament and contribute to discogenic back pain. And we have the communicating branch going to the sympathetic plexus. The safe zone of transforaminal approach was identified by Campbell in 1990. And the boundaries of this zone is the exiting nerve root anteriorly, it's called Campbell triangle, and inferiorly the superior end plate of the vertebra below, medially by the traversing nerve root, and posteriorly by the superior articular process of the pedicle below. In this picture, which was taken from the endoscopic transforaminal approach, we can appreciate the anatomy from different angles. We can see the ligamentum flavum, epidural fat, traversing nerve root, and medial to it is the thecal sac. Then we can identify the posterior longitudinal ligament, and we can identify the posterior lateral disc herniation, and we can do our surgeries. There are anomalies in the nerves exiting from the foramen, and these anomalies should be identified, hopefully before surgery, by careful examination of the MRI and CT scan of the foramen. The existence of these anomalies have been reported, which may make transforaminal endoscopic procedure contraindicated. The clinically most significant anomalies of the lumbar nerve roots are apparent courses and anastomosis between the nerves. Nader and McNabb in early 80s have classified these lumbosacral anomalies into 3 types. We have in type 1, where nerve root share common dural sleeve. In type 1B, the dural sleeve doesn't exist in the exact location, but it is more inferior or caudal compared to other levels. In type 2A and B, this is conjoined nerve root, regardless of the foramen below it occupied or not occupied. If the foramen below it is not occupied, it is 2A. If the conjoined nerve root, and there is also occupation of all foramina, this is type 2B. And in type 3, where there is connections between 2 nerve roots. The most commonly identified variation was S1 root, followed by L5 nerve root. And the most common anomaly was Nader and McNabb type 1. The anomalies were usually unilateral in the left side and show a male predilection. Nerve root anomalies present unique surgical challenges and can increase the risk for iatrogenic nerve injury. It is important to use the foraminal dissection techniques, means you identify and remove the fat and you work slowly in order to identify all structures. This enables recognition of the nerve root anomaly before the nerves are iatrogenically injured. It's considered to be a cause of failed back surgery syndrome, and it's reported in cadaver study of about 15%. Another anomaly is focal nerve. The focal nerve, it has own anterior and posterior root fiber, and it has dorsal root ganglion. This means that the focal nerve is independent nerve root. The focal nerve distributes branch to the lumbar sacral plexus. And in order not to confuse you, most of studies did not differentiate between anomalies of Nader and McNabb and the focal nerve, but anatomical studies like cadaveric anatomical studies have identified focal nerve. Maybe radiologically they will look the same, and we'll come to the radiological examination of both. It has branches going to the femoral and anterior nerve and to the lumbosacral trunk. As we see here, this is the lumbosacral trunk. In green, we have the focal nerve, which is independent nerve connecting the lumbosacral plexus. And this is of maybe clinical importance also, because sometimes single lesion can cause multiple dermatome and myotome involvement, and sometimes creating surgical dilemma, and maybe some surgeons will not operate on the patient because he doesn't match exactly the radiological findings. Focal nerve also was divided into 6 types, and the focal nerve study published also in the 80s after the Nader and McNabb classification. They are the most common cause of double nerve root contribution in unilateral radiculopathy. If we have discompressing the traversing nerve root or exiting nerve root, and as we see the L4 and L5 here, L5 causes motor dorsiflexion, motor toe dorsiflexion, and L4 causing the ankle. But in this picture, compression of single nerve fiber will cause double pathology. Focal nerve can be identified by careful examination of the sagittal and coronal MRI. As we see in this stair image, we can identify double nerve with each one has dural sleeve, and here one dural sleeve, as we see. This is focal nerve. As we see in the axial T1 image, the arrow pointing to the focal nerve on the right with anomaly large L5 vertebral nerve root and smaller S1 nerve root. And this axial T1 image showing arrows pointing bilateral S1 focal nerve. And this is also a recent MRI study published in order to identify the focal and anomalous nerve in MRI before surgery, because most of the anomalous nerves are identified either during surgery or after investigating failed back surgery syndrome. And this is the fusion image after subtracting the body, showing the anomalous nerves in the foramen, or after coming out from the dural sac. I put these images in order to increase our understanding and to correlate it with our clinical scenarios. And this provide information may help to explain atypical representation and prevent nerve injury during surgeries. Other things that we can see is the ligament, and they are of 2 compartments, external and internal. External compartment of nerves in the foramen are the corborotransverse. Corboro means body, and transverse is transverse process. So we have superior and inferior corborotransverse, which is located outside, and then transforamina, which are superior and middle and inferior transforaminal ligaments. And this published in the 70s. Transforaminal ligaments are not present in all patients. From the external compartment, the superior corborotransverse was the most frequently observed ligament. The internal ligaments were commonly found in the inferior aspect of the medial portion of the foramen, and I will show you a picture about it. There were broad attachment to the posterior aspect of the intervertebral disc and the anterior surface of the anterior surface of superior articular process. We will see it now. This is the foraminal view showing the superior and inferior corporotransverse ligament, and the internal ligament that I mentioned that is most commonly located in the inferior part of the disc to the superior articular process as broad bands connecting this two. It can be seen preoperative and as we see in this cadaveric specimen. Also, CT scan, careful examination of it in axial and coronal and foraminal window with magnification can identify these ligaments before surgery. Based on the transverse diameter of the neural compartment, around 30% of the foramen is occupied by the nerve root. The existence of the ligament significantly reduced the space available for the foramen. It is hypothesized that this ligament diminished the space available for the nerve root within the foramina, but the exact clinical significance of the ligaments in causing nerve root compression and low back pain has yet to be established. There was no evidence that those ligaments exert any pressure on the vessels or the nerves in the foramen. It is necessary to distinguish the ligaments from nerves using transforaminal endoscopy so the ligament can be cut out without damaging the nerve. Thorough understanding of the anatomical characteristics and distribution of these ligaments may reduce the operation time and improve the efficacy of surgery. In conclusion, microanatomical details is increasingly important with emerging minimal invasive techniques and consequently reduce exposure. For years, neurosurgeons have used laminectomy and facetectomy for foraminal and extraforaminal disc herniation, which demonstrates the important articulation of the spine. Knowledge of the anatomy of this area is going to contribute to their ability to handle pathology, use a different lateral approach, and to avoid sacrifice this joint. Thank you.